So it's good to meet you today, Paul. And again, it was a real pleasure to have you lecture to the Society. You were talking about your basic science understanding of muscle physiology, particularly following immobilization, and also a bit about the effects of inflammation. Can you tell me what first made you interested in muscle wasting?
Well, when I started out, I was only really interested in exercise, and exercise is a powerful stimulus. But of course, what you see in intensive care patients is a real rapid loss of muscle mass. I mean, you're talking kilos, which is extremely quick. So that drove really the ideas, if this negative effect can be so fast, what is driving it? And so now my views are actually shifting quite a bit, where I now believe that actually the combined effects of immobilization and trauma will be a far greater negative stimulus than any positive effect of exercise. And really we don't understand clearly the mechanisms playing a part, because you don't really see a patient where mass is disappearing so fast that isn't both immobile and has an infection or major trauma. So we're steadily trying to tease apart the relative contribution, and I find that is extremely interesting, because once you know the dominant drivers, then you can choose the best approach to try and offset that.
So if we were exploring perhaps what your main message was from the basic science you were reviewing today, and we were looking for the clinical context in which to think about this, clearly the surgical patient faces within post-operative recovery a period of immobilization, and there is the opportunity for exercising the patient both pre-operatively and post-operatively to try and counteract that. Now, it seemed that you're developing thoughts about, well, which is the most important thing to focus on.
Sure.
And naturally, we within the ERAS program have focused on trying to deliver the patient to theatre in the fed state and well hydrated, and not having undergone immobilization prior to surgery. And we try to get them mobilized as soon as we can post-operatively, but that will vary from one patient to another. There have been attempts at pre-operative rehabilitation, so-called prehab, particularly for the elderly and frail patients. And I'm interested in where within this paradigm that we see at the moment, the accent on trying to prevent immobilization at or during the time of surgery, shortly after, or an accent on exercise in a rehabilitation context or in a rehabilitation context.
Sure.
Where do you think the maximum benefit will come?
Well, I think from the context of just immobilization, it's emerging that the negative effects on muscle protein synthesis and muscle insulin sensitivity is extremely quick. So we're talking, within hours that you're having a debilitating effect. So the effects of exercise, certainly on protein synthesis and glucose uptake, can persist for up to 24 to 36 hours. So you could translate that to think that exercise performed immediately preoperatively could have a protective effect to immobilization. But then, of course, patients have the surgical trauma, and also possibly added infection. And I think there, this is a major, major negative drive. I would very much doubt that exercise could protect at the site of local trauma. Maybe in the periphery, but, and I think the best approach there would be anti-inflammatory approaches, probably, if possible, in the days prior to surgery. Of course, you don't always know that the patient is going to require surgery, but some patients you do, and I think that would be a real interesting scenario to mine down into. Can you blunt the muscle inflammation that occurs as a result of trauma by treating a patient before surgery?
So, I mean, that's a very interesting model that you're presenting for us to consider in terms of the optimal metabolic control of patients for major surgery, in that your understanding of the basic science of this is that these changes that occur in muscle following immobilization are very quick in onset, and therefore we have to be very aware that the optimal strategy is to avoid those periods of immobilization, because the onset of these things is extremely fast.
That's right.
But and perhaps the rate at which they come on and the effect that they have on muscle mass and function is in a shorter time scale than the benefits that can be got from exercise. Is that one of your?
I think, you know, it's a really interesting conundrum. So I believe exercise can have a protective effect. Whether exercise, you know, delivered immediately post-surgery can protect, I don't know. There's also the added problem that, you know, to recruit a large muscle mass, you're going to need a large current, and that can be particularly painful. But with a small muscle mass like the forearm, you could probably, you know, use something like a TENS machine to deliver contraction, and that may be effective. But something like the quadriceps muscle group, it becomes more difficult. And it could be, however, that, you know, more regular physiotherapy may actually protect. And I'm talking about, you know, as soon as possible post-surgery to get the muscle contracting. Because we know, you know, as you saw in the presentation, within 24 hours of immobilization, you have a 40% reduction in muscle glucose uptake. So it is extremely fast.
So, moving on to the concept that you also raised about inflammation. Obviously, the surgical response to injury involves an inflammatory response. Sure. And you're wondering about whether we should be concentrating on modulating that inflammatory response to get a better preservation of muscle mass and function post-operatively.
Yeah.
What kind of strategies would you feel would be relevant to do that?
So I think pre-treatment of a patient with drugs that are known to modulate the inflammatory response would be very interesting. And
well, there have been studies. Henrik Kellett's done work with dexamethasone in patients, for example, who are undergoing relatively minor surgery.
Sure.
And it has benefits, particularly in terms of mood and post-operative nausea and vomiting. And it's given at a relatively small dose. Do you feel that a drug such as dexamethasone should be used at a higher dose or more widely, or do you think there should be an alternative approach?
Well, for certain, I do know that dexamethasone at clinical doses can suppress LPS-induced increases in muscle pro-inflammatory cytokines, because we published in that area. But of course, at higher doses, dexamethasone is also catabolic, So there would clearly need to be a way of titrating dose and looking at the relationship with protein metabolism and glucose metabolism. But there are other anti-inflammatory approaches, some from nutrition-based. What I think, when I look at the literature, I see a lot of these studies measure circulating cytokines, and I think that is a bit of a red herring, because what we find out in our research is actually there's a dissociation between the systemic inflammatory response and the muscle inflammatory response. So when looking at these approaches, you need to measure muscle inflammatory status. But other, drugs that are used to treat insulin sensitivity, pioglitazone, rosiglitazone, they have anti-inflammatory properties. And a useful strategy would be to start thinking about using these in the trauma situation.
Obviously, some of your work has also focused on aging and the muscle-associated loss that we see in elderly people. How do you feel the basic science of our understanding of what's going on in that situation relates to how we should manage these particular patients in the perioperative period? Do you feel that in terms of mobilization strategies or anti-inflammatory strategies, we should be targeting these people in particular, or should we be treating them the same as younger individuals? What do you feel that are the particular challenges of managing the sarcopenic elderly patient?
So I think the first major challenge is we do not currently know what the drivers of sarcopenia are in humans. I personally think that a decline in physical activity is a major driver, much in the same way as immobilization is. So we first of all need to differentiate aging phenomena from physical activity phenomena. Once that's been achieved, then I think you can start looking at the role of trying to increase physical activity in the elderly to try and maintain muscle protein metabolism, trying to maintain muscle insulin sensitivity in the elderly. Because then it will clearly be seen as not as an aging phenomenon per se, but a physical activity phenomenon per se. And actually, if you look at the patients that have very low levels of habitual physical activity, like chronic obstructive airways disease, these patients respond extremely well to exercise interventions. So many of the phenomena, this weakness, frailty in COPD that's been related to almost a muscle myopathy, is actually probably enormous muscle deconditioning. And exercise has a powerful approach to play there.
And how long do you feel a period of reconditioning needs to be in these patients? I mean, obviously, many of the patients that are within an ERAS pathway have cancer, and they're on a program to have their treatment within a set time frame. And do you feel that a rehab program as short as 2 or 3 weeks may be useful, or does it have to be longer?
Well, when you look at the studies that have come out of patients that have, for example, I go back to COPD. So these patients in pulmonary rehabilitation, where they're using exercise as an intervention, within 6 to 8 weeks of regular supervised physical activity, you can see clear positive effects on muscle mass, muscle strength, fatigability, and even their general scores for quality of life are dramatically improved. So, I'm not saying 1 or 2 bouts of exercise, but certainly 6 to 8 weeks, you can get clear, measurable effects.
Now, one of the more recent themes that we've seen developing is the problem of the obese patient
Sure.
with gross muscle wasting,
Sure.
a sarcopenic obese patient.
Sure.
And certainly some of the recent literature identifies them as being at particular risk of complications and death following major surgery. Do you have any thoughts about what strategies we should be developing to manage those kind of patients, Paul?
Yeah, well, we published a paper earlier this year showing in healthy elderly obese compared to healthy lean elderly people, that sarcopenia doesn't exist. So actually the muscle mass is not lower in obese, healthy elderly people. The quality of the muscle is severely diminished. So that then begs the question, then what is it in these individuals, patients that you do see a lower mass? Is it really the obesity that's driving it, or is it something else? And my guess would be it's probably physical inactivity that is driving this response.
And in terms of a prehab or a management strategy at the time of operation, what can we do for these kind of patients?
Sorry, which patient are you?
The sarcopenic obese elderly patient.
Well, I think that what we do, it's a difficult question because we don't know why they're losing their muscle mass. I mean, when you do see some, extremely low muscle mass in individuals and enormous levels of lipid when you look at mid-thigh, for example, mid-thigh MRI. So it's whatever intervention you use is not going to be quick. I think obviously weight loss would be one intervention, but that is not easy. But a number of companies are now developing drugs that are muscle specific in terms of their targeting, and there are several groups that have shown, for example, testosterone administration in the elderly does increase muscle mass, does reduce fat mass, does increase muscle quality. The problem is testosterone chronically is not really a major viable therapy, but muscle-specific androgen receptor agonists are being developed. Myostatin inhibitor drugs are being developed that will target muscle, and I think that would be a very interesting approach to look at these individuals. Because of course sarcopenia is not just the loss of muscle mass, it's a loss of muscle mass and a decline in the quality of the muscle. And so it'll be interesting whether these drugs also are able to improve the quality of the muscle. For example, by reducing the lipid content of the muscle. We know testosterone, and we've known for many years, testosterone also reduces fat mass, which could be just as important as the increase in lean body mass.
So it's an exciting time.
It's very exciting. Yeah, it's interesting to be able to translate findings from animal studies into healthy individuals, and then move that into a patient environment. It's great to be able to interact with clinical colleagues like yourself, to actually who see these patients on a daily basis. I don't see surgical patients, but when you see the effects that surgical trauma have on muscle, it does make it very exciting, and it does make you want to go to work every morning.
Well,
yes.
Thanks again.
Thanks.